I'm Dr. Nguringa Kevin. I'm a consultant physician and interventional nephrology, currently working at Parklands Kidney Center. So first is to understand what hemodialysis is. It's a renal replacement therapy modalities. For you to be able to conduct dialysis, you must have a reliable vascular access. So vascular access is what we use to get blood from the patient, take it to a dialysis machine, remove the waste products and toxins, and return the same blood to the patient after having a session of their treatment. You can also have peritoneal dialysis, which also requires accesses, but the focus of our talk is on fistulas, which is different from PD accesses. So fistula fast in action basically means for us to be able to conduct hemodialysis, you must have a reliable vascular access. So there are two types of accesses, a central venous catheter and an arteriovenous access. So the plan is always to have an arteriovenous fistula, and it's because they have less rates of infection, less complication, and less hospitalization from catheter-related bloodstream infection, and hence a fistula-fast policy. The question would really be, when do you have this discussion over fistula-fast being discussed with our patients? So once your patient is in stage 4 of chronic kidney disease, you begin this particular conversation, and which now makes us have this fistula-fast in action into play, because not all patients then qualify to have a fistula created on them due to their different unique challenges, and therefore you need to identify this early on. We are currently working on our Kenyan guidelines on vascular access and vascular access preservation methods. Currently we use the international best practices and from the European Renal Association and from the American Society of Nephrology. But in terms of a regional approach, in Kenya we are still trying to develop our guideline in vascular accesses. To our physician, the call of action is simple. I keep saying primary care physicians meet nephrologists basically at such conferences, but more important is we need to stop working in silos, and stopping working in silos means working in teams. Working in teams improves the efficiency and access to fistula fast in action. It has actually been shown if we don't work as a teams, the rates of creation of fistula is less than 50%. In terms of governance and regional approach, governments need to invest more in infrastructure, capacity builds in order to increase the human resource, and this will be in turn increase the number of people who are having fistulas being created. So my call to government is more investment, more education, integrating chronic kidney disease in our national strategy, and finally but not least, going to the communities and trying to mop up the people who have chronic kidney disease in order to retard this particular progression of disease. So ASCOCOP, which is a regional body for training, we are hoping through the Kenya Renal Association, which has developed training guidelines through the Care Nephro project, which is going to run for the next 5 years, that we can be able to offer more training in the regional by capacity building the existing schooling structure. One of the things is through implementation through the Kenyatta National Hospital, East African Center for Excellency. The intention is to have training, a 2-year training program in nephrology that will hopefully increase the human resource not only in Kenya but the region. And we hope this year at the sidelines of this conference we'll be signing a memorandum of understanding with ASCOCOP to train our physicians in nephrology through a 2-year program. And this 2-year program will hopefully have an interventional nephrology rotation, which will expose our students to a fistula fast policy and different aspects of interventional nephrology.